Ravinder. We're going to talk about a complex case, I think, tricuspid. Ravinder is the director of our program, structural, and Jaipur trained here at Sinai and in St. Louis, and doing a great job. Actually, one of the prolific, I would say, the tower or other structural proctor in India, and going to show something new. All right, Ravinder.
Thank you, Dr. Sharma, for the kind words and for the invite. Good evening, everyone. And so the complex cases were the cases which we saw earlier today. This is a complex case scenario. 67-year-old lady, hypertensive, diabetic, prior cardiac surgery ×2, last being a 25 millimeter St. Jude epic valve in 2009, now presents with severe bioprosthetic valve regurgitation, severe TR, PAH, enlarged right ventricle with normal RV function, atrial fibrillation, signs of heart failure, frailty, and was a surgical turn down for redo cardiac surgery. This is the transesophageal echo, which clearly shows a flail bioprosthetic leaflet and severe mitral regurgitation. And this is the tricuspid valve, severe tricuspid regurgitation and non-coapting tricuspid leaflets. So the plan was to do a transcatheter mitral valve replacement valve in valve, 23 millimeter sapien 3 transeptal approach, and probably do an ASD closure for the septum because patient already had enlarged right side of the heart. And then a staged tricuspid valve treatment, which was earlier discussed by Dr. Vinny Bapat, and which I'm going to show. This was a CT scan assessment, and this was the routine. We already saw TMVR procedures, TE-guided septal puncture, dilatation of the septum, agilis sheath, JR catheter crossing the valve, a confida wire in the left ventricle, and then dilatation with a 10/4 balloon. However, the valve was not crossing, and then we found out from the surgical notes that the mitral valve was replaced from the right atrial approach, and that is why the septum was very tough, and there were sutures placed. So we did a double balloon dilatation, and we went ahead and deployed the 23 millimeter sapien 3 valve, and this is the 3D echo which shows the valve positioning, and the mean gradient post-procedure was 4 millimeters of mercury. And this is the atrial septal defect, and you can clearly see the bidirectional flow there. So what do you do with the septum, the ASD? Because of the enlarged right side of the heart and severe tricuspid regurgitation, we decided to close the hole with the 12 mm ASD device. So we followed this patient for a month, and just to see what happens to the tricuspid regurgitation and what happens to the right-sided symptoms. So this patient came back for a follow-up, and patient still had persistent severe tricuspid regurgitation on high doses of diuretic and deranged liver function test, and signs of low cardiac output, fatigue, and various other features. So the echo still showed severe tricuspid regurgitation. This was the CT scan analysis of the right side of the heart. You can see the tricuspid annulus is 46.8 millimeter. And these are the various dimensions of the SVC 28. The dimension of the IVC at the level of hiatus is 37 millimeters. And you can see the enlarged hepatic vein, and it's very close to the point where the IVC opens into the right atrium. And here in the right lower column, the right lower picture as well, you can appreciate the enlarged IVC, enlarged hepatic vein, and the point where the IVC enters into the right atrium. The therapies which were available in our country, as of now, there was no therapy available, so we decided to do a Caval valve as a compassionate ground and enroll this patient in the ongoing first-in-man trial. So we did a hemodynamic assessment. First thing is advance the catheter, end-hole catheter into the pulmonary artery. And you can, on the right side, you can see the PA pressure mean is 25, which shows that there is no severe pulmonary hypertension as of now. And which was, the PA pressures was high before TMVR, but in 1 month, the PA pressure came down to mild pH. This is the right atrial pressure. You can see a large V wave of almost 25 millimeters. And the reason why the V wave, you need a significant V wave is because this valve is implanted at the Caval position, that is at the level of IVC RA junction. And this is our first case which we are doing. And just to understand the hemodynamics, you need some amount of pressure in the right atrium for the leaflets to close towards the IVC side. So we went and put a wire in the right atrium, put a pigtail in the right atrium, did a right atrial angiogram. Multipurpose was parked in the hepatic vein. So this multipurpose was parked to identify where the hepatic vein enters. The Lundaquist wire was parked in the SVC. And this valve, just to tell you the detail, it just comes in two sizes. One is 27 and one is 35 mm valve. The 35 mm valve was chosen as it was the bigger valve. And this is the picture of the valve. It has a covered portion of the skirt which is 23 millimeter long. The diameter is 35 mm. And the 47 millimeter is the diameter at the lower portion of the stent frame. And it is implanted in such a way that the skirt is above the hepatic vein, and that's where the hepatic venous flow is not impeded. The valve is slowly deployed. The end hole catheter is parked in the hepatic vein. And you can see you can see a fluoroscope. You can appreciate a fluoroscopic demarcation between the covered or the skirt segment of the valve and the non-covered segment of the valve. And then we did an RA angiogram to document there is no reflux into the hepatic venous system. The hepatic vein angiogram was done to see that the flow is not impeded. And this is the transthoracic. This patient was not a fit candidate. She was not fit candidate for general anesthesia. So we just did under conscious sedation. This is a transthoracic echo, which you can appreciate the movement of the leaflets just where the IVC enters into the right atrium, and the hepatic venous flow also normalized. This is a pullback from right atrium to the IVC, and as it was discussed by Dr. Vinay Bapat as well, the visceral circulation was protected from the elevated pressures in the right atrium. And there was a clear-cut difference between the RA pressure and in the IVC pressure and the hepatic venous pressure as well. So this was a successful TMVR with 23 millimeter sapien 3 and a Caval valve implantation with 35 millimeter trach valve. Patient was discharged on the second day. I mean, it's too early to comment anything, but we'll be closely following this patient because she had no other option, and this was a compassionate use of a Caval valve implantation. We are learning about new transcatheter tricuspid valve therapies, and it's just the follow-up and more data which is going to enlighten us. Thank you very much.